Hello, my name is Carl Yannick. I'm a clinical adjunct professor of neurosurgery at Indiana University. I'm here to talk about neural element injury. This chapter establishes a framework to help you think about neuronal injury and death. Many mechanisms described involve experimentally confirmed and hypothesized mechanisms of injury. The purpose of learning about these mechanisms is to help you base your treatment of spinal disorders on the root cause of neural injury. There are three main mechanisms. One, cell disruption. This leads directly to cell death. Number two, cell distortion. This is not quite as bad as disruption, but it can lead to it. Number three, metabolic derangements. Think of this as chemical disruption, leading to osmotic shifts, anaerobic respiration, and ultimately apoptosis or necrosis if not addressed. In an injury, there are two components to it. Primary injury, which is there's nothing really to do here but prevention. We can't fix this kind of injury. We can encourage helmets, seatbelts, education, and awareness. There's also secondary injury. This is the spine surgeon's primary focus. We will focus on neural element distortion. Neurochemistry and neuropharmacology are really beyond the scope of this chapter. There are four basic mechanisms of neuronal distortion relevant to our study of this chapter. The first is compression. This is the most common issue. Compression can result from degeneration or injury at any location around the cord. For example, anterior causes of compression include a herniated disc, osteophytes, OPLL, and burst-type fractures. Posterior causes of compression include hypertrophied ligament, facet disease, and epidural hematoma. The key is to remember that something extrinsic is putting pressure on the spinal cord directly. The next issue is distraction. This is an independent mechanism from compression. Distraction appears to result in neural element distortion as well as blood supply disruption. The third mechanism is sagittal bowstring. This involves a combination of stretching and compression. It is best exemplified by a spinal cord pulled taut over a focal kyphosis. The last is coronal bowstring. This is similar to the sagittal bowstring, but in this case, the spine is pulled tight over a focal point in the axial plane, such as a centrally herniated disc. With these mechanisms of neuronal distortion in mind, we can infer three mechanisms by which spine surgeons can cause neural element injury. First mechanism we'll examine is inappropriate width of decompression. Of course, if it is too narrow, then the structure that is to be decompressed is likely not to be decompressed. If it is too wide, an iatrogenic instability may cause persistent neural element injury. The second mechanism is inappropriate length of decompression. If it's too narrow, there's a risk of sagittal bowstringing and or compression, as the neural elements are kinked around the decompressed region. If the length is too long, again, we risk iatrogenic instability. This is most commonly noted at the cervicothoracic junction, if there is laminectomy without fusion. Finally, if there's unrecognized aberrant anatomy, there can be a problem. You need to familiarize yourself with common anatomic variants such as a duplicated nerve root, transitional levels, and cervical ribs. Now that we have a sense of the micro level for neural element injury, we can consider common spinal cord injury syndromes. The first is complete myelopathy. This one involves some sort of controversy. There is no question that if someone has a cord transection, there is no recoverable function below that level. However, with most injuries being cord contusions, you must put someone through a battery of tests before concluding there is complete myelopathy. The chief prognosticating factor in this case will be pinprick sensation, which is carried by the spinothalamic tract. The next syndrome to consider is anterior cord syndrome. This involves the loss of motor and pain sensation, but preservation of positional sense. This entity is very important to distinguish from a complete myelopathy since it has a much better prognosis, especially if addressed early. The next situation is Brown's acquired syndrome. This is a classic case and a favorite of board examiners. It involves the ipsilateral loss of motor and position sense, along with the loss of contralateral pain and temperature. The key here is examining for potential reversible causes. Spinal stroke is not reversible, but a laterally impinging meningioma is. The classic example is trauma with impalement or stabbing. The spinous process prevents the object from crossing the midline. Central cord syndrome is the last spinal cord injury syndrome to consider. It is a constellation of signs and symptoms involving especially upper extremity weakness that is worse than lower extremity weakness. There are also often sensory disturbances, such as allodynia. The central aspect of the lesion is thought to be due to a vascular cause. This pattern also aligns with the classic model of somatotopic organization within the spinal cord, where hand function is more central than leg motor. The prognosis after a central cord syndrome is quite variable and is heavily influenced by age. Thank you for your time.